In this presentation, we'll be examining the remaining human herpes viruses that we still haven't examined yet. But first, I want you to have a slide that includes the various terms or the various names of different exanthems. In our country, people sometimes use the Arabic term, sometimes they use the French term, and sometimes they use the English term for these different exanthems. So let's go on to discuss the Epstein-Barr virus, the cytomegalovirus, and then the human herpes viruses 6, 7, and 8. Starting with EBV. The Epstein-Barr virus is usually transmitted in saliva, and then, so when it's replicating. And so it replicates in the epithelial cells of the pharynx and salivary glands, and during this process early on, it will infect the B lymphocytes present in the oropharynx. These B lymphocytes will help spread the infection to the rest of the body. And during this period, what happens is that naive B lymphocytes are infected. A lifelong latency is then established in memory B cells. So even if after the first or primary infection subsides, what will happen then is that the virus is still residing in these memory B cells. You could have viral reactivation and then shedding of the virus again. So during this shedding, you reseed the lymphocytic compartment. At the same time, you can shed the virus in the saliva and then be contagious to somebody else. The incubation period from the first time you've acquired the infection until you possibly see a manifestation is 4 to 7 weeks. I should note that the majority of our community, the majority of adults are positive or seropositive for EBV. They've already previously encountered this virus. You should also know that EBV can immortalize B lymphocytes both in vivo and in cell culture in vitro. However, when it immortalizes our B lymphocytes in vivo, these are cells that are cleared by the immune system. However, you might end up with a cancer later on in life, and EBV is associated with various types of benign growths and cancers. EBV, just like the other human herpes viruses, doesn't seem to have an animal reservoir, so it's only seen in human beings. If you get infected with EBV after the incubation period, the primary infection is usually asymptomatic for the majority of people who get the virus. If you get infected with it as a child, you might have flu-like symptoms, but for most people, you don't see a manifestation. Manifestations are more seen in adolescents, more so than adults. And here what you see is that 35 to 50% chance of causing infectious mononucleosis. This disease is also referred to as glandular fever or colloquially as kissing disease. So this is a term that is kind of frowned upon. So we don't like to use the term kissing disease that much. It's not quite scientific, but it's something that you might hear people using as a term. Infectious mononucleosis is a self-limiting disease, but what are its manifestations? The person who has IM presents with fever, sore throat, fatigue, as well as swelling of the lymph nodes, enlargement of the spleen, and occasionally jaundice. The complications, though, are rare. It is a self-limiting disease. When you have infectious mononucleosis, this is usually accompanied or often accompanied by the production of what we call cold agglutinins. These are antibodies, usually of the IgM isotype, that in the lab can bind red blood cells at 30 degrees. So if you're thinking in terms of within our body itself, so of course colder areas in our body, specifically the limbs where it's usually cooler, this is where these might bind red blood cells. And so because they can bind red blood cells, this can cause hemolytic anemia. However, when the symptoms of infectious mononucleosis resolve, what happens is the hemolytic anemia also resolves. The symptoms resolve within a couple of months. However, rarely chronic infectious mononucleosis might happen. And in these people who have chronic infectious mononucleosis, uh, what eventually happens is a lymphoproliferative disease that results in patient death. Now, if you remember from the first lecture, I kind of explained the concept of latency compared to persistence. So usually we think of herpes viruses as latent viruses rather than persistent viruses that cause consistent shedding. However, reactivation of EBV is really common, and so it is kind of borderline persistence rather than latency. However, we do go through dormancy phases where there are no uh, viruses being produced, and so that is technically a latent type of infection. And upon reactivation, you don't usually see any symptoms. However, the person can shed EBV, and so the person is contagious, although the person is not symptomatic. Less than 10% of patients who have reactivation show symptoms, and the symptoms have various or variable severity. However, you worry about the immunosuppressed because reactivation can be quite severe in that population of patients. EBV is associated with various types of cancers and growths. So some of these examples include Burkitt's lymphoma, which is a jaw tumor. So this is more seen in African children. Nasopharyngeal carcinoma, this is an epithelial cancer, mostly associated with Asian populations. By Asian, I'm not referring to Middle Eastern populations or our population, mostly Far Eastern populations. Lymphoproliferative diseases and immunocompromised are also associated with EBV. Oral hairy leukoplakia is seen with EBV, possibly. So this manifestation is not a cancer. This is wart-like growth. This is what it looks like here on somebody's tongue. So it's seen in some HIV infected subjects, also in patients with with immune suppression or some um, suppression that is drug-based. For example, transplant recipients, they're usually given immunosuppressive drugs, and this could lead to an epithelial focus of growth of EBV, such as the example you're seeing in the picture here. X-linked lymphoproliferative syndrome, this is due to a mutation that uh, basically disrupts the ability of natural killer cells and T cells to mediate the killing of EBV infected cells. The diagnosis of an EBV infection includes the heterophile antibody test, which is more commonly referred to as the monospot test or the mononuclear spot test. Heterophile antibodies are antibodies that can react with cells from a different species. So in infectious mononucleosis, what happens is the production of antibodies that can react with red blood cells from horses, and so we can utilize this property to conduct a lab assay, which is the monospot test. However, you should know that the efficacy and the sensitivity and specificity of this test is rather debatable. Some sources say that's quite good, and some other sources have doubted this, and so this has led to some authoritative bodies abroad to say that we should not really rely on this test. So keep that in mind. Serology may also include IgM or IgG detection for anti-EBV antibodies. Hematology, if you examine the blood smear under the microscope, you might see atypical lymphocytes, such as the one you're looking at here. These are cytotoxic T cells. Histology can be performed to diagnose malignancies, and you can always try and isolate the virus and enhance the sensitivity of downstream tests that you might conduct. Treatment usually, again, cater to the symptoms. So there is no antiviral medication that's recommended for an EBV infection. One thing you should know is that some antibiotics like ampicillin and amoxicillin are contraindicated for secondary infection during an EBV infection since they typically induce a rash when you have mononucleosis. There is no vaccine, but there are some under investigation. For the next part, we will discuss the cytomegalovirus, or CMV. CMV is not highly contagious, so unlike varicella-zoster virus, for example, which we discussed in the first session. This is not highly contagious virus. However, it has many transmission modes. A mom can transmit it to her infant, so congenitally, during birth, via breast milk. You can also transmit this virus by contact with body fluids, saliva, urine, and blood, which can contain the virus. It can be transmitted by sexual contact or via transplanted organs. And just like the other human herpes viruses, it has no animal reservoirs that we know of. The incubation period is variable depending on the group we're discussing, so the time between acquiring the virus and having the manifestations. However, on the average, it's about a month. Um, when you get the infection as a primary infection, so the first time you encounter this virus, um, do not really exactly know if it goes first into a specific tissue, gets replicated there, and then spread. Because unlike, for example, with the cartoon we looked at when we were examining varicella zoster virus, where the progression of the viral infection has been quite well studied, we do not really entirely understand how this process happens here, but we know that it's likely to be systemic because studies have shown that the virus can be isolated from various sites after you are first exposed to it. So we believe it is simply a systemic primary infection all over the place. Um, and most commonly, the infection, primary infection, is asymptomatic. We don't see any manifestations. However, much less frequently, probably less than 10%, we see infectious mononucleosis-like manifestations. And we should know that most of us are positive or seropositive for this um, infection by the time we are adults, since about 90% of the population in developing countries are seropositive, and about 40% in developed countries are seropositive for CMV by adulthood. Reactivation is believed to be uncommon, and if it does happen, it's usually asymptomatic. However, you worry about the immunocompromised because you might have severe manifestations there. So, in somebody who is immunosuppressed or somebody has a weak immunity, both the primary infection and reactivation are more severe, and reactivation happens more often than in somebody who's immunocompetent. Some manifestations include encephalitis, retinitis, pneumonia, and gastroenteritis. So the populations at highest risk of having CMV primary infection or reactivation with severe manifestations are AIDS uh, uh, patients and organ transplant patients. And you should know that cytomegalovirus is the most common agent to complicate transplantation, possibly resulting in loss of the organ that was transplanted. There are, of course, other populations at risk, other populations who have weaker immune systems. Newborns, for example, can also develop severe infection. Again, we can relate that to the status of the immune system. The cytomegalovirus is an important virus to discuss when we're examining possible congenital and perinatal infections. So if the mother encounters this virus for the first time and she has what we call the primary maternal infection, she carries a 30% risk of transmitting the virus to the fetus or the baby. If she is already seropositive, there's a 1% risk that she might transmit this virus to the fetus or the baby. So you might have a congenital or perinatal infection. These terms, so congenital refers to the time of pregnancy, during pregnancy, that is. And perinatal indicates the period surrounding or around birth, so shortly before and after birth. So if you have congenital or perinatal infection in the fetus or baby, most likely the baby will be asymptomatic. Nothing will happen. So 90 to 95%, so the majority of these fetuses, they don't have any manifestations. However, later on in life, they might develop late sequelae. So about 7 to 25% have possible deafness or learning deficits. This is 7 to 25% out of the 90 or 95% that were asymptomatic. So that's a rather small percent of people who end up with late sequelae despite not having any congenital or perinatal manifestations as fetuses. On the other hand, in the lesser a proportion of fetuses who or babies who get the infection as a congenital or perinatal infection, 5 to 10% are symptomatic. And what they have is what we call the cytomegalic inclusion disease. And the results of such manifestations are growth retardation, retinitis, microcephaly, jaundice, and hepatosplenomegaly. So what happens to this rather lesser proportion of fetuses who acquired this infection as a congenital or perinatal infection? 20% of them will die, so you end up with loss of the pregnancy. On the other hand, 50 to 80% end up with permanent damage, and so you have mental retardation, possibly, or deafness and blindness. So why is this virus important to consider with congenital or perinatal types of infections? This is the most common congenital or perinatally transmitted virus. So it's only second to Down syndrome as a known cause of mental retardation. As a rough estimate, roughly about 1% of live births in Lebanon are estimated to be infected with the cytomegalovirus. The diagnosis of CMV may rely on serology. So, for example, if you look at IgG, this could tell you if somebody who's planning to get pregnant is immune to acquiring the infection, and if the lady is not immune, then she should try and avoid possible sources of infection during pregnancy. You can also do PCR for the virus. You can try and isolate the virus, and you can also conduct histological analysis of affected tissues. You can do, for example, hematoxylin mucin staining, and this is what you're seeing here is a classic manifestation of CMV. This is the cytopathogenic effect or the cytopathic effect, the CPE of CMV, is having these owl-eye cells, so they look like the eyes of an owl. These are nuclear inclusions, so this is a large nucleus. This is a replication hub for the virus. So if you remember from our viral replication presentation, we talked about how most DNA viruses, they replicate in the nucleus, and that includes CMV. So treatment may rely on, again, cyclovir, valganciclovir, or scarnet in specific cases, and you learn more about these drugs when you discuss pharmacological agents against the viral agents with Dr. Zreib later in the course. We don't have any vaccines for CMV, and some are being developed. Moving on to human herpes viruses 6 and 7, these are roseolo viruses. Human herpes virus 6 is quite common in the Western world, and so by adulthood, about 95 or up to 100% of the population are already seropositive for this virus. However, some studies in our country indicate that we have a much lower percentage, probably closer to 40 to 60%. Usually primary infection happens in childhood. So this is a pediatric disease seen in babies who are 4 months up to 2 years old. And what the infection causes is what we call roseola infantum. This has multiple other names such as baby measles, 3-day fever, because as you will see, it causes fever that lasts 3 days. It's also called exanthum subitum and sixth disease, because it's one of the 6 diseases of childhood. And here's a quick exercise for you. Go ahead and look for what the other 5 are, but this is one of the 6 common diseases of childhood. So if you're going to have your primary infection, which usually occurs in childhood, and you see manifestations including fever and rash and the rash, if it's going to happen, it's a macular rash, so it's flat, and it appears after fever has subsided in about 10% of cases. So you might have this intense fever or fever that lasts 3 days without any rash. So the rash only happens in about 10% of cases. You could also have febrile seizures and other complications that could occur. We don't usually think of HHV6 as an infection that happens in adulthood because primary infection is usually rare. However, if it does happen, you might end up with mononucleosis-like manifestations or possibly hepatitis. We don't worry about reactivation in somebody who is immunocompetent. You worry about it in somebody who is immunocompromised. However, because CMV is quite common in the population, it's kind of difficult to trace whether manifestations seen to reactivation in somebody who's immunocompromised. It's difficult to figure out whether these manifestations are due to human herpes virus 6 or due to CMV, because CMV will almost always reactivate along with it in somebody who is immunocompromised. Human herpes virus 6 and human herpes virus 7 know or we believe that transmission happens via oral secretions, possibly via breastfeeding. Um, Replication after primary infection is thought to occur in the salivary glands. And the incubation period after you encounter the virus and before roseola is thought to be about 10 days. We don't know how long the person is contagious when they have this virus. And we know that latency happens just like with other herpes viruses, but latency happens in lots of different tissues, lymphocytes, monocytes, central nervous system, and so on. We don't know of an animal reservoir that harbors this virus, just like the other herpes viridae we've been discussing in these two sessions. Diagnosis, it could be reliant on the clinical manifestations. We have a rather classic presentation for roseola. You rarely have to go for serology. And culture of this virus is rather difficult, so isolation is difficult. There is no antiviral therapy, and so treatment is symptomatic. And we don't know, or there are no vaccines for this virus. On the other hand, human herpes virus 7 is quite similar to HHV6 in its biology and its ubiquity as far as we know. It might also cause roseola and phantom. However, disease associations are poorly established when it comes to this virus. And like the other herpes viruses, we don't know of an animal reservoir that harbors this virus. And the last virus we will be discussing in this family of viruses is human herpes virus 8 or HHV. This virus is also referred to as Kaposi sarcoma-associated herpes virus or KSHV. HHV8 is the cause of Kaposi sarcoma. Kaposi sarcoma is a manifestation that shows plaque-like papular lesions. So these are plaque-like skin lesions, but these might also affect the mouth. Infection might affect the gastrointestinal tract and the respiratory tract. If it affects a major organ system like the liver, the lungs, then you might have a high mortality rate. The lesions have variable growth rapidity, so not all of them will grow in a similar manner. And people who have Kaposi sarcoma who are tested for HHV8, they always end up being positive for the HHV8 DNA, indicating that HHV8 is very likely the causative agent of these lesions. Now, we don't usually associate seeing Kaposi sarcoma with somebody who has a good immune system. However, that is possible, and you'll see cases where you might have Kaposi sarcoma, such as middle-aged men of Mediterranean descent. This condition is an AIDS-defined disease. So what I mean by that is that if somebody is HIV positive, you won't say this person is an AIDS patient, and you learn more about this concept with Dr. Visit later on in this course. So if somebody is HIV positive doesn't mean that they have AIDS. However, Kaposi sarcoma is an AIDS-defining disease. You might also see it in somebody who doesn't have AIDS, such as transplant patients, so due to immune suppression, or like I said earlier, middle-aged men of Mediterranean descent, they might also have show Kaposi's sarcoma. HHV8 is also associated with vascular tumors and with pathogenesis of body cavity-based lymphomas that occur in subjects who have AIDS. HHV8 has also been associated with multicentric Castleman's disease. This is a disease of non-cancerous growths that might later become malignant. These are growths that affect usually multiple body sites. Usually it's growths that happen in lymph nodes. And 50% of these growths have been associated with HHV8 DNA positivity. This is a slide that shows you what these lesions look like. These plaques of Kaposi's sarcoma are deep red, as you can see, and they have different sizes because, like we said earlier, they have variable growths. The seropositivity of human herpes virus 8 is low among subjects who are immunocompetent in industrialized countries. However, it's more frequent in some Mediterranean and African countries. So overall, it is low in the West, and it is more frequent in the Mediterranean basin and some African countries. However, in some risk groups, regarding of the geographical region, the seropositivity is high, namely in men who have sex with men. Transmission includes both sexual and non-sexual routes. However, both of them are poorly understood. Sexual routes are believed to be through oral secretions. There are no animal reservoirs, just like with the other human herpes viruses. Diagnosis includes possibly histology of Kaposi's sarcoma or of tumors. You can also use serology, but that's mostly a research tool. You can also use PCR, but it's not quite common for human herpes virus 8. Treatment is symptomatic, so we don't have antivirals that are recommended for human herpes virus 8. So you may manage the underlying cause of immunosuppression, and that might slow or prevent the tumor formation. And we don't have a vaccine for human herpes virus 8 at the moment. And this concludes this presentation. If you have any questions, please let me know. You can contact me via the email provided on the screen, and I'll get back to you. Thank you for listening.